To Co-John Bishop Toguingwa. Thanks for the introduction, Wendy. Thanks for the invitation to speak. I hope you guys have all enjoyed the food festival. I'm going to talk a bit about celiac disease and the gut. As Wendy said, I'm a pediatric gastroenterologist, so that's sort of my area of interest. Broadly speaking, the things that I'm going to try and cover are the effects of celiac disease inside the gut. So what damage occurs to the gut in celiac disease, what effect this has on how the gut works and how it functions. I'm going to talk a little bit about the microbiome, which Claire will also talk about, and I believe Suzanne also mentions as well. So hopefully there's a bit of a thread going through this above and beyond just it all being about celiac disease. Talk about how this causes symptoms and what problems may arise as a result. So as you're all aware, the cause for celiac disease is complex and multifactorial. You won't develop celiac disease unless you have one of two genetic markers which you're born with. But about 30 to 40% of us carry those genetic markers, and only somewhere between 1 and 3% of the population develop celiac disease. So it's not just a directly inherited disease. There must be something else that triggers it off. Now, clearly, eating gluten is an essential part of developing celiac disease. If you're not exposed to gluten, even if you've got the predisposition, you won't develop the disease. But again, almost all of the population will eat gluten early on in their lives, and only a small proportion develop celiac disease. So there must be something else alongside that that triggers off the immune system to cause the damage. And what happens when the immune system is triggered is that some of the immune cells in the body, the T cells in the blood, react to develop antibodies against parts of the gluten molecule, which then attack the lining of the bowel. And the trigger for that developing is not clear, and there may be some role of the microbiome or the kind of internal bacterial ecosystem of the gut in that pathogenesis, in that cause of developing celiac disease. So what is happening inside the gut when you have celiac disease, and why does that matter? Oh, sorry, I've done that. Sorry, I'm going backwards. Told you I was half asleep. Was that the... Yeah. So in health, the gut is lined by millions and millions of tiny finger-like projection called villi, and they in turn are lined by microvilli, and that provides the absorptive surface of the gut. So the gut is folded and folded and folded, which gives a very large absorptive surface. When you've got immune-mediated injury in celiac disease, those little villi all get shortened and blunted and broadened, and the absorptive surface reduces as a result. They also get quite inflamed, which affects some of the function of the gut as well. When you lose villi, not only do you reduce the physical surface for absorption, but you lose some of the enzymes, particularly the lactase enzymes that can help you absorb and digest sugars in milk. And you are unable to fully absorb nutrients from your diet, both the macronutrients, and those describe the large groups of nutrients that are important for growth and energy, but also the micronutrients like your iron and like your minerals and like your vitamins, which are all important for general well-being and for various body systems to maintain health. Inability to absorb the macronutrients, the main nutrients that you need for energy and growth, can lead to weight loss, can lead to poor growth. But inability to effectively absorb the micronutrients can lead to other problems such as anemia, such as bone demineralization, particularly if you're not being able to absorb your vitamin D and your calcium. And other micronutrient deficiencies states can arise if you can't absorb other minerals or vitamins such as zinc or the fat-soluble vitamins. Malabsorption of gut contents also draws fluid into the gut, which can drive diarrhea, and also acts as essentially a food source for bacteria within your gut. If you've got unabsorbed food items, the bacteria feed on them, cause fermentation, produces gas, which in turn can lead to bloating and discomfort. Moving on to talk a little bit more about the microbiome. As I say, the microbiome is a term which describes the complex ecosystem of millions and millions of bacteria, fungi, and viruses that live within the gut. It's estimated that there are more bacteria within your gut than there are cells in the human body, so it's a really important and large part of a human being, actually, the bacteria within us. And generally speaking, we live in good harmony with these bacteria. In fact, they have some beneficial and useful roles to play in terms of some forms of nutrient digestion, in terms of vitamin, particularly vitamin K synthesis, in terms of how they help regulate the body's response to infection and other toxins, and in production of some anti-inflammatory compounds such as short-chain fatty acids, which are particularly important for colonic or large gut health. And we know that individuals with celiac disease have changes or differences in their microbiome as compared to people without celiac disease. So they seem to have fewer of some of the beneficial bacteria, such as bifidobacter, which has anti-inflammatory properties and immunomodulatory properties, and lactobacillus, which similarly produces anti-inflammatory proteins as part of its function. In contrast, people with celiac disease seem to have more of the more harmful bacteria, such as Bacteroidetes, and Bacteroidetes can impact on the mucus layer within the gut that provides protection against the gut from permeability to toxins or harmful agents. So we know that the microbiome is different, but what does that mean? Does the change in microbiome indicate that that's part of the cause of celiac disease? Is it just a consequence of developing celiac disease, that having celiac disease changes the environment internally and encourages the growth of different bacteria, or is it just a mere chance association? Well, this is an area of ongoing interest and ongoing research, but there is increasing evidence that the microbiome or changes in the microbiome might be part of the underlying cause for developing celiac disease. Some of that is pretty circumstantial. It's interesting to note, certainly, that the prevalence of celiac disease seems to be gradually increasing. Now, part of that is related to better diagnosis, better awareness, both from the general public and hopefully from within the medical profession. But part of it may be because the environmental effects on us have changed over the generations, over the decades, as there's greater industrialization, greater hygiene, hopefully greater immunization rates, all of these things which impact on our well-being as a whole, but may drive some forms of diseases. So we know that diabetes is becoming a little more common, allergies becoming more common, food intolerances and celiac disease are becoming a little bit more common, and that may relate to changes in the overall environment. We also know that these adverse changes in the microbiome, or so-called dysbiosis, actually occur before celiac disease manifests. So there have been a number of studies, albeit fairly small numbers, which have shown that if you look at infants and children who are at risk of developing celiac disease, there are differences in the microbiome in those that go on to develop celiac disease from those that don't. So again, suggesting that this might be part of a trigger for the process to occur. Again, somewhat circumstantial, but we also know that some of the factors which influence the microbiome quite markedly may also be associated with the increased risk of developing celiac disease. Now, some of these factors are debated and are somewhat controversial, but there are certainly studies to show that celiac disease seems to be a little more common in people that have had the people born by cesarean section, in individuals who had exposure to a lot of antibiotics in infancy and early childhood, and in those who had recurrent gastrointestinal infections. The data on breastfeeding is, as many of you may know, somewhat more controversial, and there's no really good evidence to suggest that breastfeeding, whilst it has many very positive benefits, has a great protective effect against developing celiac disease. But is this all just circumstantial and coincidental evidence, or is there a strong scientific explanation as to why the microbiome might have a causative role in celiac disease? Well, there are a number of things that that certainly could support this theory. We know that an unhealthy microbiome may weaken the gut barrier and therefore making it more likely that potential immune-stimulating products can get into the gut and drive the immune response. We also know that the increased presence of harmful bacteria can directly promote inflammation to the gut. And some of these bacteria also produce products that almost mimic gluten that also might provide further stimulus for an immune-mediated form of damage. So certainly some scientific evidence for why this might be the case. Okay, so dysbiosis may contribute to the cause of celiac disease, but does it cause symptoms? Well, we know that in other circumstances it certainly does cause symptoms. In individuals, for example, with irritable bowel syndrome, where there's recognition of an abnormal gut microbiome, people experience symptoms that overlap or in some cases are indistinguishable from those symptoms experienced by people with celiac disease. And why might the dysbiosis cause symptoms in celiac disease? Well, this may be due to direct damage to the intestinal barrier, to the intestinal function from harmful bacteria, or the harmful bacteria may damage the intestinal wall, which directly causes a result on the immune system, which drives further inflammation. It's also worth noting that the bacteria themselves are metabolically active, so they break down gut contents. And some of the products of breakdown of gluten in individuals with celiac disease may stimulate the immune system more and triggering a worsening inflammatory response and worsening symptoms. But there are a lot of unknowns, and there are a number of other questions that it would be interesting to know more about and to explore. We know that around about sort of 30% of people with celiac disease have persistent symptoms even on adherence to a gluten-free diet. And it's recognized that whilst adoption of a gluten-free diet may modify the microbiome somewhat, it doesn't completely return it to normal. An individual's microbiome, whilst not set in stone, is quite well fixed, usually in infancy or early childhood, and anything that we attempt to do can maybe modify it a little bit, but often doesn't return it to normal, so to speak. And is that persistent dysbiosis, persistent abnormal microbiome, a cause for ongoing symptoms despite a gluten-free diet? Is differences or are differences in the microbiome a reason why some people with celiac disease have certain symptoms and other people have completely different symptoms or even no symptoms at all? We don't, in all honesty, know. It does raise questions that potentially open up opportunities for how we can move things forward for people with celiac disease. Does knowledge of the dysbiosis open up new ways to treat celiac disease, or at least to treat the difficult refractory symptoms that persist despite a gluten-free diet? The bad news is that there's no way you can give up your gluten-free diet just yet. Gluten-free diet remains the only effective treatment for celiac disease, and there's no evidence that ways that we might change the microbiome, such as using so-called friendly bacteria, probiotics, using prebiotics, which are foods that feed healthy bacteria, or other ways to change the bacterial microbiome. There's no evidence that these can reverse celiac disease. There are a few studies that suggest that for difficult symptoms, despite a gluten-free diet, there may be a role to try probiotics, but there's certainly not enough evidence for that to be a universal recommendation for people with celiac disease. And I would, as a note of caution, mention that some probiotics and prebiotics may contain gluten, so as you do anyway, do look at labels and make sure you're being safe in your consumption. Beyond treatment, is there a way that knowledge of the dysbiosis might lead us to ways to prevent development of celiac disease in at-risk people? Unfortunately, not yet, but the future is out there and hopefully bright. So my take-home messages from this brief talk are the impact of celiac disease on the gut is profound, and if not treated, can lead to both difficult symptoms and longer-term complications. The role of the gut microbiome in celiac disease is an area of great interest, but certainly may have a role to play in both the causation of the disease and the symptoms associated with it. But to date, the only effective treatment for celiac disease remains a lifelong gluten-free diet. Thank you very much.
Oh, yeah. No, I can hear it now. I couldn't hear it over there. Do you want me to carry on or wait? I'll speak loudly above it. Oh, good. Kia ora tātou, ko Clare Wall tōku inga. Hi, everybody. My name's Clare Wall. I'm Professor of Nutrition and Dietetics at the University of Auckland. More importantly, I have a daughter who's 28 years of age with celiac disease, and she was diagnosed at 10 years of age, and I've been involved with celiac New Zealand for quite a long time. I want to talk to you about dietary fibre for celiacs, which actually complements quite a bit of what John's been talking about. We're talking about the microbiome and the gut, and actually that there could be some positive things that we can do for celiacs to improve our gut bugs by consuming more dietary fibre. So I want to talk about what it is, why it matters, and how do we get enough. So why talk about dietary fibre? Well, dietary fibre is essential for our gut health, and I'm sure that you all probably know quite a lot about dietary fibre and how important it is to keep us regular. But actually we also know that it's much more important than just keeping our bowels healthy, but it's also very important for feeding our gut bugs, our gut microbiome, and has other health advantages. There are some significant health advantages of eating a high fibre diet to improve our microbiome. What we do know is that many celiacs struggle to get enough dietary fibre, and it's not just celiacs, actually everybody does. In New Zealand, we probably only eat about 2/3 of the dietary fibre that is recommended for health. We know it's easier for non-celiacs to get more dietary fibre because they can get a lot of their fibre from things like wheat and barley and rye, and celiacs have to rely on other types of grains and other types of foods to get their dietary fibre. And often many gluten-free products are quite low in fibre, so the swap-outs, the breads, the baked products, etc., are actually, some of them are reasonably low in fibre, although I'd have to say, going out there into the gluten-free food show, there are a lot more products now that are actually quite a lot higher in fibre. There is still quite an over-reliance in the gluten-free diet of things like white rice, corn, and other starches, which tend to be low in fibre. So what is dietary fibre? So dietary fibre comes from plants, so it's an integral part of the plant. And if we look down here at the anatomy of a whole grain, so let's think about whether that be, obviously not wheat for celiacs, but let's think about brown rice, for example. Thank you. We can see that a whole grain, so an intact grain, has a sort of husk on the outside of it, and it's got a germ bit as well that's associated with part of the bottom side of the grain. Now, the bran and the germ are, the bits that basically are the dietary fibre of the grain. They're the bits that don't actually get digested in our gut and go through into our large bowel. But they also have got lots of other goodies in them. So they've got lots of nutrients and other important minerals, which are really important for a healthy diet. Now, when you take the bran off a grain, so that's something like white rice, for example, because it's had the bran removed from the outside, you're removing that component of the dietary fibre. So when we recommend that people eat high-fibre foods, we're talking more about whole foods and eating, like the skins on fruits, etc. Thank you. So there are two types of fibres. There's soluble fibre and insoluble fibre, and they occur in sometimes together in the same food, but sometimes they're richer in different foods. So soluble fibres they dissolve in water and they form gels. So I think of them sort of a bit like a sponge in your gut. So they go into your gut and they take up the water and fluid in your gut and form like soft sponges. And that's really important for softening the contents of the gut and helping things move nicely through you. It's also important because they attract other things like some of the sugars in our diet and some of the sort of less healthy fats like cholesterol, and they slow down the absorption of those into our body. So they also have a really, more sort of helpful properties as well. These soluble fibres go through into our large bowel, and our microbiome, our gut bugs, really like eating them. So they eat them, they get their nutrition from them, they ferment them, and they basically try and prevent some of the dysbiosis that John was talking about. So they try and keep your gut microbiome healthy. So soluble fibre tends to be found in things like apples, beans, psyllium, and citrus fruits. Then we have the other type of fibre, which is called insoluble fibre, and I liken this a bit to a broom. So the insoluble fibre is a dietary fibre that isn't soluble in water. So it's quite a tough fibrous material, and it goes through into our large bowel and adds bulk to our stool, which also helps it move on down. So it's a bit like a brush. It kind of helps brush everything out of your bowel and down into the toilet. So it adds bulk, supports regular bowel movements. So insoluble fibres are found in things like nuts, seeds, vegetables, and some of the gluten-free grains. So having a mixture of both of foods that contain both these soluble and insoluble fibres provides us with the best kind of health benefits. So why is fibre important? So I think I've hopefully convinced you it keeps us regular, it helps prevent constipation, it keeps us fuller for longer, and that's really the property of that soluble fibre. Because it is like a sponge in your gut and takes up water, it helps the food move through your digestive tract, and it helps keep you feeling full. And so that also might help reduce your appetite. So for people who are trying to maintain a healthy weight, it can be really useful. It can help manage cholesterol and also blood sugar levels because of that kind of sponge-like effect. And also fibre supports gut bacteria and intestinal healing. And the other really important thing that it does is support mental health and well-being. And you think, goodness, how can dietary fibre in your gut help with your brain health and mental health? Well, basically your gut is like your second brain. So your gut is, talking to your brain the whole time, and your brain is also talking to your gut. So whatever goes on in your gut and the types of food that you eat and how healthy your gut is really impacts on your health and well-being and your mental health. So I know John talked about the microbiome, so just to kind of sort of summarize it, I suppose, in terms of the importance of dietary fibre. When we think about dietary fibre and the importance of it feeding our healthy gut bugs, we think about dietary fibre in a prebiotic sense. So I'm sure you're all quite familiar with the word prebiotic and probiotics and antibiotics. So prebiotic means it's the fibre, it's the food that's feeding our gut bugs to keep them healthy. And our gut bugs is called the microbiome. So what do these gut bugs do? Well, they help break down that dietary fibre that we can't actually digest and absorb. So they ensure that it basically provides more food to proliferate the healthy gut bacteria. They produce bioactive molecules which also support our gut health. They synthesize vitamins, particularly vitamin K, which John's already talked about. They protect the gut from bad bacteria. So the more good bacteria you have inside your gut, the more likely it can fend off the bad bacteria that you don't want in your gut. They also produce bioactive molecules which help support brain health, and they help shape and regulate our immune system. So not all is lost with the dysbiosis of celiac disease. We can actually try and proliferate good bacteria by eating more dietary fibre. Let's look at some gluten-free, fibre-rich foods. So in terms of grains, we've got things like quinoa or quinoa, buckwheat, brown rice, some of the more whole corn products, and then some of the more ancient grains like teff, sorghum, millet, and amaranth. Some of these are obviously quite expensive and not as accessible, but some of the more common ones like quinoa, buckwheat and brown rice you're all probably really familiar with. The other good source of fibre are legumes, so things like lentils, chickpeas, beans and peas. Fruits and veggies are a great source of dietary fibre, particularly if you're going to eat, obviously, fruit with the skin on. You can have a potato or kumara with its skin on. Berries and leafy greens and broccoli and peas again. The humble pea that you get out of your freezer, really accessible, great source of dietary fibre and nutrients. Nuts and seeds are another very good source, like things like chia seed, flaxseed, almonds, sunflower seeds. And then for people that struggle to get enough fibre in their diet, there are obviously gluten-free forms of dietary fibre as supplements. So psyllium is one of those popular ones. But just if you're buying a fibre supplement, obviously check the label to make sure that it's not contaminated with gluten and that it actually is gluten-free. How much dietary fibre do we need? So adults need about 25 to 30 grams per day, and it's recommended for people with diabetes or with heart disease to have even more, so about 38 grams per day. Now, the average New Zealand diet, as I say, we probably only consume about 20 grams per day, so we're quite well below the recommended intake for health. Children need fibre, but it's sort of it should increase with age. So obviously infants don't need much dietary fibre, and as a child gets older, the recommendation is to increase the dietary fibre intake accordingly. Now here is a table, a list of foods that are high in fibre, common serving sizes, and the amount of fibre that they contain. And you can see, like for fruits, that would be an average apple size in terms of an average-sized apple, pear, banana, a half a cup of berries. That would contain about 3 to 5 grams. Vegetables, so half a cup cooked, that's about 3 to 4 grams. Whole grains, half a cup cooked, about 3 to 5 grams. So you can see that actually, even though these are reasonably high fibre foods, to get up to your 30 grams per day, you actually need to be eating quite a lot of fibre-rich foods. And you need to also probably eat fibre-rich foods at every meal to make sure that you get enough fibre in your entire day. In terms of practical tips, one thing that's really important if you don't eat much fibre in your diet is to actually increase the amount of fibre you eat in your diet gradually. Because for a lot of people, particularly with celiacs who might have a bit of irritable bowel, actually eating some of these fibre-rich foods can cause quite a lot of bowel discomfort, so you might get quite a lot of bloating. So increase it gradually, and very importantly also to make sure that you consume enough water when you're eating fibre. Because of that action with the soluble fibre where it takes up water and produces that nice soft sponge through your gut, if you don't drink enough water, it can actually be quite a hard sponge and actually can get stuck in your gut. So always drink plenty of water with it. Importantly, choose minimally or whole and minimally processed gluten-free foods. Check labels for fibre content just so you can get used to the kind of average amount of fibre per serving for specific foods. And try new recipes, particularly with legumes. I know a lot of people don't eat beans and pulses and lentils and things like chickpeas. And a lot of people don't particularly like them or don't really know what to do with them. So think about how you might gradually increase them in your diet. I always think chili's a great example of that. So you've got your mince and you throw in some red kidney beans, and slowly over time, that's what I used to do with my kids, take out more of the mince and put in more of the beans until they persuaded that they liked it. Eat at least 3 serves of veggies and 2 serves of fruit a day, so make sure you get your 5+ a day because great source of fibre and other nutrients. This is just a sample high fibre gluten-free menu. So breakfast you might have a gluten-free muesli with chia and berries, lunch quinoa and chicken salad with veggies, snacks things like apples with almond butter or popcorn or nuts, dinner a stir fry with veggies and brown rice, and for a sweet treat, maybe a baked pear with some walnuts and yogurt. So you have to think quite consciously about having a high fibre food item in each meal. So my take-home messages are: fibre is vital for digestive and overall health. Celiacs often need to make an extra effort to get enough. There are many safe, gluten-free, high-fibre foods available now, and small changes over time can make a big difference. Thank you.
I'm going to hit just some key things for you guys, and hopefully you'll get something out of it. The first one that I wanted to talk about is I do a newly diagnosed webinar seminar, and I talk to them about 4 ways to shop gluten-free. So this isn't inclusive of everything, but this is just a really cheap guide to how to shop for gluten-free. So what I wanted to say, first of all, is that there is an abundance of gluten-free foods available that we have at our fingertips. So starting, I guess if you go to the supermarket, starting at the outside of the supermarket, your fruits and vegetables, your meat, your raw meat that hasn't been processed with anything, poultry, seafood, eggs, plain nuts and seeds, minimally processed dairy products, fats and oils, and your gluten-free grains and grain alternatives. So it should be easy, shouldn't it? Easy peasy. So the next step that I say to people is look for the gluten-free label. Now, you would have been out there today having a look around, and some products have got gluten-free written on their product. That means legally that it is gluten-free. It is safe for you to consume because they've gone through, they've done the test. We know that it's got very, very limited, no detectable is the actual criteria, gluten within the product. So they are safe to consume. Our legislation in New Zealand and Australia is the same, so we've got the same rules. So you'll find if you go over Trans-Tasman, it will be the same there. The difficulty then comes if you go further afield than Australia, in which they have slightly different rules. The next step that I tell people to do is have a look for our cross-grain logo. Who has seen it already? Who has got a product in their bag with the cross-grain logo on it? It looks like this. Who's seen it? Yeah. So this is a really good, easy visual way for you to be at the supermarket and have a look at products that have partnered with us here at Coeliac New Zealand, and they've undergone testing, so they are gluten-free, and they are proud of it. That's why they wear a little logo like that. They're like, look at us, we're doing well. So, you know, we want you to support them where you can because they are really looking after the gluten-free community. And then there becomes a difficulty. I think it's just about a PhD in being able to read food labels. Who has got a PhD in reading food labels? Who is becoming a bit of an expert, though, in reading food labels? Who didn't realise there was so much rubbish written on a food label? Honestly. Yeah. The products that you didn't think would have gluten in it, and now you're looking at it. Yeah, it's really astounding, actually. I guess the safety barrier for us as consumers is that if it has an allergen on it, so specifically here we're talking about gluten, it has to be written on the product in the ingredients list and in the contain statement. So it has to state that it's got gluten in it. And that's where the easy part then becomes difficult. So what we say when we're teaching people to read labels is look for the acronym, which is BROW. B stands for barley. Give her a star. R. Oh. So this is a wee picture of an ingredients list on the back of your packet. So they make them really small, right? So that you either go, oh, I can't be bothered doing this in the supermarket when everybody else is in the supermarket, or you bring a magnifying glass, get down on your knees, and you really study them. So the first part of it is all your ingredients that they've put into the product. And in there, they have to state the allergen, and they have to state it in the allergen name, specific name. And then, so this is your ingredients, like that. Often say on a side note that if it's got over 150 ingredients in it, I'm really wanting to buy that product anyway. And then we've got the contain statement. So it's often called contain statement or allergen statement, and that also must state the allergen that is within the product. So easy peasy, eh? Yeah. And then there's the exceptions to the rules. So these are kind of good exceptions though. So whilst we advocate if it says wheat in the ingredients to avoid it, there are some wheat process-based products that are safe to consume for people with celiac disease. Not for people with a wheat allergy, but for people with celiac disease. Now, not on this slide, because it's always controversial, but in some of the training that I've done, I do talk about the PAL. Does anybody know what the PAL is? It's not really a PAL. No, the PAL is the precautionary allergen labelling. Has anybody seen that statement? May contain. Yep, may contain, in a factory that may contain. What does that mean? It either contains it or it doesn't, does it? So, no. And this is the bane of everybody's existence with the may contain. So I'm going to tell you a couple of things, and it's not going to really help you, but I'm going to tell you anyway. So the may contain is voluntary. So legally they don't have to have it on it. So it may contain, it may not contain. They put it on there to mitigate any possible cross-contamination risk that possibly ever might, could, or could not be present within their factory, those sorts of things. So there's no measurement, they don't measure anything, they have no legal requirement to, nobody follows it up, whether they have it or not, the statement, that's what I'm talking about. So it really leaves consumers in a bit of a bind. Do I buy that product because it doesn't contain gluten, because I've read the contains and it doesn't say gluten, but it may contain gluten, you know, so where does that leave me as a consumer? This is where I'm going to say it kind of leaves you in a bit of a pickle sometimes. So at Coeliac New Zealand, we advocate for people, particularly people that are newly diagnosed, to avoid that if they can. Avoid those may contains, because unfortunately we don't know the risk. It doesn't contain it as an ingredient, but we don't know what's happening in the factory. We assume, and we shouldn't assume, because what do they say? There's an arse in assume. You know, that they've done their due diligence with food safety in the factory and all those sorts of things, but we don't know. I do know, and Wendy will know better, is that they are working on this. So they are working on putting some restrictions on being able to put this statement on packaging, and that's for the consumer's benefit. So we know what the risk is, whether it's zero risk and they're just kind of writing it because, you know, they had the labels already printed, or whether there actually is a risk to us when we're consuming it. So, you know, not very good news for you right at the moment, but my key take home is that they are working on that. If you are newly diagnosed, then try and avoid it, okay? And unfortunately, sometimes when you look at some of the products, a lot of them will say may contain. But join Coeliac New Zealand, find other members, talk to them. They know the best products, the best shops, the supermarkets, those sorts of things. So we've got a great network and a great community in which we share all those kind of ideas and thoughts and spaces throughout the country. And I just wanted to have a brief talk about some core nutrients that may be low in a gluten-free diet. Claire has already talked about fibre, so I won't go on about fibre. B vitamins and calcium and vitamin D, John touched on. I actually just wanted to touch on iron, because I like iron. It reminds me of being a muscle man. So I have done a pre-recorded presentation. If anybody's been on our YouTube, anybody? Hands up. Hands up higher. Google Coeliac New Zealand and YouTube, and we've got a wealth of recorded presentations that we've done, and these people, experts, have done them too. So have a look on that. They're free to kind of access. On that, I did iron and celiac disease for Women's Health Week, which was in August of this year. So I just wanted to kind of pinpoint a couple of things around iron, just about the importance of it. So as you know, it's an essential component of our red blood cells. And it's also important in lots of things, as all nutrients are, aren't they? When we say this nutrient's really important, we mean all of them, don't we? Really. So some common signs and symptoms of being deficient in iron. Now these look very familiar, don't they? Anybody feel like one of them today, yesterday? Yeah, maybe possibly tomorrow. Unfortunately, they're a little bit non-specific, but specific enough to be something that we all might feel at some stage. So I guess highlighting the fact that we should be looking at our iron levels and making sure that they're checked regularly through our general practice, through regular blood tests. Who is at risk? So I put women here, but men, you're also at risk. Yep, I just wanted to highlight that in case they kind of went, not me, you are. But women particularly, because of our menstruation cycle, because of our extra need during pregnancy and breastfeeding, we are often more at risk of iron deficiency. Also, if you eat a vegetarian or vegan diet, if you have erratic eating patterns too, or restrict your diet over a period of time, you could be just at an elevated risk of lower iron levels. And of course, those that have underlying conditions, e.g. celiac disease. So here you are. So how much do you need? This is a really good table just to highlight the difference in ages and stages, and particularly in women. Okay, so if we're looking at our young, so you can see there the RDI, the recommended daily intake, is between 9 and 10 for both males and females of that age. And then we get older, we become a teenager, or we've been a teenager. And then we're into adulthood, and women, 19 to 50. See how it increases from toddler to teenager to adulthood. And then if you're hapu, if you're having a pregnancy, it's elevated even more. So what does that mean, though? I mean, 9 grams, can't you just put that in your hand? A couple of teaspoons, isn't it, of iron? We always talk about nutrients in terms of recommended daily intake, and then you have to practically put it into, well, what does that look like in a day? And Claire did that really well with fibre, in a daily diet, because we don't eat nutrients on their own either. So there's 2 forms of iron that we get within our food. There's heme and non-heme. So heme iron is the iron that's found predominantly in our animal sources, and that's the one that's more easily absorbed. Oh, I've just been given the hoozle up. Faster, faster, she says. So this is, on the right-hand side, you can see the milligrams of iron content per different food source there. And then we've got non-heme, which is predominantly found in our plant-based foods or iron-fortified foods. And it's less bioavailable than heme iron, but you can still access it as a good iron source if you're on a vegetarian or vegan diet. And there we go there. So you can see brown lentils down there. That's got quite a high iron intake too. And just wanted to highlight there are things that particularly enhancers of iron. If anybody's ever been on an iron supplement, it's usually with vitamin C, because that helps enhance the absorption in your body. That's the reason for that. And John did talk about gut health, and I just wanted to highlight a couple of key, I guess these are lifestyle things around how to improve your gut health. We could talk about enjoying a diverse whole foods-based diet, so making sure that you eat a variety of minimally processed foods. Variety is the spice of life, so trying to access that is really good for your gut health. Incorporate probiotic foods. So I'm a big advocate for whole foods, so any kind of nutrient or bacteria that's positive for us, I do advocate for people to try and access it through their foods, if at all possible. I realise it's not always possible, but there's some potential food sources of probiotics. The same there for prebiotics. And then another one is managing stress. So stress plays a huge impact on everything, but it also plays an impact on your gut microbe. So you will often notice, like Claire mentioned about the brain being the gut being the second brain, you will often notice if you're having issues with, a high-stress job, high-stress family, whatever it is, that sometimes that comes across in gut disturbances or gut upsets too. So whilst I can put it there and say manage stress and do it, go and do it today, harder than it looks, but it does play a role in a healthy gut microbe. As does getting enough sleep. We all need a really good sleep process. And staying physically active as well. That plays a role in the mobility of your gut microbe. And drinking plenty of fluid. I just wanted to also mention around the time frames. I often have people that come up to me and say, I'm not feeling that good. I've been diagnosed, I've cut out gluten, and I kind of talk to them about, well, how long has it been? And it's been maybe 6 weeks. So you have to realise that the gut will take time to heal. It's not going to be an overnight instant relief from you. So, for some people it is shorter than it is longer, and for some people it is longer. So just making sure that you manage those expectations around, giving your gut time to heal itself. Also just wanted to highlight some of the work that Coeliac New Zealand have been doing for our membership and the wider gluten-free community. So we have rolled out a new advanced training for gluten-free food safety. It's called the Gluten Free Food Safety Masterclass. And what it enables is hospitality, cafe staff, restaurant owners to be able to undertake some really good quality, good food service, food safety training around what is celiac disease, what is gluten, where is it in the kitchen, how can we mitigate cross-contamination, how can we talk to customers, how can we support people that require a gluten-free diet as part of their medical treatment. So this is what we've rolled out in the last 18 months, and we're pretty proud of it. I do want to kind of disclaimer it by saying this is not an audit, so we have not audited these places that have undertaken this training because that requires too much on both ends, and it's not a practical, feasible process that we can undertake at the moment. This is just giving them the opportunity to undertake some really good training because they are wanting to improve their processes and services for you out in the community. And the patient registry, if you haven't talked to the ladies at our stall, we also have a patient registry up and running in collaboration with Coeliac Disease Foundation. And so that gives us an opportunity to gather a good database of people with celiac disease within New Zealand, because that's pretty lacking. And it also gives people an opportunity to know about any kind of clinical trials that are going on that they might be able to access through that. And again, YouTube channel, go and Google Coeliac New Zealand YouTube channel. There's some really great resources for you and your family in that space.
Hi everyone, kia ora katoa, I'm Dr. Paul Hamilton. I'm the Clinical Director with Pacific Clinical Research Network, and I don't have 37 slides, don't worry, I'm going to make this nice and quick, relatively informal, and just really want to give an update on some of the great clinical trials and research which is currently happening with celiac disease right here in New Zealand. There are opportunities to join these trials, they're all completely voluntary, but if you have some interest after I've given my little talk, please come out and see the team out at the booth. They're just past the masterclass area over there. It's been a real privilege to be around the Gluten Free Food Festival today, especially amongst people who understand firsthand the challenges of living with celiac disease, whether that's personally or through connection with a loved one. So what I'll do today is just talk very briefly through some of the clinical research and latest developments in the celiac disease space and some of the clinical trials and some of the early results which we're seeing with trials which are running here in Auckland currently. So you might well wonder, although I think you've all been sitting here throughout the last 3 talks, so hopefully it doesn't come as too much of a surprise, why do we still need to do any research? We already know that gluten's the problem, right? But the truth is, although we've come quite a long way, there's still no effective cures for celiac disease. We are dependent on adherence to a gluten-free diet, and although we can help to manage symptoms with that, as we've seen, 30 to 40% of people continue to experience some symptoms even with good adherence to a gluten-free diet. Now, partly that can be the issues around the food labelling, being able to not only select foods in your own home, but out in the community, going out to restaurants, things like that. But there can also be refractory cases of celiac disease where even with good adherence to a gluten-free diet, there may be some ongoing symptoms. So, clinical trials, I guess I'll just give you a little bit of background on that, and it's basically how we're going to be able to move forward with new treatments, better diagnostics, and even preventative strategies. And every medicine that we test or use today has started at some point in a clinical trial. And of course, none of that's possible without the volunteers and participants and patients that come and join our clinical research trials and give up their time in the hope of perhaps finding something better for themselves, but certainly looking forward to the future and finding better things for the community in years to come. There's two sort of main goals with a clinical research trial, or indeed the development of medications overall. First of all, we need to know that the medicine is safe. We need to know that it's tolerable, that when you take it, it doesn't cause a side effect, and that it doesn't cause any problems down the line after you've been taking it for a while. So safety and tolerability is at the forefront of all of the trials. The second thing is, does it actually work? So the efficacy measures, and we need to be able to look at efficacy measures and really see whether or not they are useful in terms of the disease process. So there's sort of three main ways that people look at efficacy with celiac disease. And of course, first of all, one of the most important ones is, does it help to relieve symptoms if there's gluten exposure? So symptomatically, do people actually get better when they take the medication? In addition to that, there's also what people term biomarkers, or they might be blood tests or stool samples or other markers which might indicate that something biologically is changing in the gut or in the blood system in response to the treatment. And then thirdly, we'd also want to know about what's happening in the gut, what's happening in the lining of the intestines. Is there actually any change there? And so those are really the three main areas which people are looking at to determine whether or not the medication might be working. I've really been involved in clinical research trials now for about 15 years, and I was reflecting on this and sort of putting a little talk together today. That really, our first one that we did here back in Auckland was around 2015. So it's about 10 years, really, that there's been some celiac research happening here in Auckland, at least those which I've been a part of. And I think there have really been sort of three main challenges which we've yet to fully overcome, and with that initial trial along with subsequent ones up until very recently. The first thing has really been in selecting an appropriate group of people, so the volunteers and the population of people that enrol into the trials. Some trials you could accuse of cherry-picking their participants. They've had a very, very selective group, and they've controlled the situation so well that it just doesn't reflect the real-world exposure and the challenges which people face in inadvertent gluten exposure out in the real world. So although you may get a really good result in the clinical trial, it doesn't translate once you have a larger population or you're trying to market a new medication and see whether it actually works out in the community. So that's been one thing. A really clear understanding of the mechanism of the disease for celiac has also been really important. As you've heard today with John's talk, there's really an interplay here between a food intolerance, components of autoimmunity, the role of the microbiome, and probable environmental exposures. All of those factors are coming to play. And having a really good understanding of what the underlying mechanism is which drives celiac disease for some people but not others is very important. And then finally, just translating all of those study findings into real-world improvements in symptom control. So as I mentioned, some medications have performed very positively in clinical trials, or at least in the early stages of testing, but they've actually really made no difference to people's experience of their symptoms. And that's been seen either in the larger late phase clinical trials or once the medication is starting to be marketed in sort of post-marketing trials. So hopefully what everyone gets from that is that there is still a need for research. It remains real, and with up to 100,000 Kiwis with celiac disease. I'll just touch on some of the interesting and promising new treatments which are currently being developed and with trials underway here in New Zealand. So first of all, just a little bit of background. Pacific Clinical Research Network, we're a group of researchers and clinicians with sites across New Zealand, and we're working with hospitals, universities and industry partners to run high quality clinical trials. And our goal is to make research accessible, safe and meaningful for study participants, and hopefully find the next treatment which may provide some benefit to a wider community outside of those that are participating in the clinical trials themselves. So often when people think of a clinical trial, they're thinking about being a human guinea pig, and it's got a number of negative connotations, of course, but I want to just reassure everyone that you're never just a number when you're participating. You're a real partner in research, and often when I talk to people about enrolling in a trial for the first time, I say, you're one of 3 people in a research relationship. We've got the drug company, the sponsor, they're the ones who are responsible for making the medication. They come up with a hypothesis to test it, and they provide the study protocol. Then you've got people like me working at the research site. So the doctors and the scientists that work there, their role is to faithfully follow the trial protocol, make sure that we do all of the assessments, give people the right dose of medication at the right time, and take the tests to make sure that it is fulfilling those goals of safety and efficacy. And then thirdly, there's the participant, of course. So their job is to make sure that they follow their instructions, they take the medicine faithfully in compliance with the protocol, answer questionnaires about their health, and tell us about any sort of changes, whether that's an improvement or if they notice an adverse effect or any sort of problems. So it's really absolutely critical to have good volunteers who give up their time to participate in research trials like this. And just as important, if not even more so than either the sponsor or the study doctor that you might be visiting. Participation generally is going to involve, just briefly, attendance for some clinical trial visits. So you come over to the centre, have some blood samples or other sort of tests such as vital signs and ECGs, things like that. There'll be some questions to answer, questions about your health, any medications that you're taking, anything which you've noticed since we've last seen you. And then there'll be, of course, a study medication to take. Sometimes it might be a placebo, sometimes it might be a real thing. These things vary depending on what the trial is, but we can talk through all of those details with you, and you're certainly never left in the dark as to the potential risks and benefits, as well as all of the requirements to be involved. So I'd just like to touch now just very briefly, and I'm going to use an example which is Forte Biosciences, and it's one which you can look up. I'm using this as an example because they've had a recent press release with the first phase of trial results, which was a trial which we participated in New Zealand, and it's now moving forward into the next phase of testing. So it's been some really positive results, and I use this as an example, but we've actually got another couple of other studies which are running currently. All of these medications for the trials which are running at the moment are using antibodies. So similarly to your own immune system producing these antibody-type proteins, which are very good at binding onto something specific, these are medications which have been designed to bind very specifically to the overactive part of the immune response, which is causing problems. And there's a pathway in particular which is currently being targeted, which is the interplay of, won't go into too much detail on it, but CD122 and interleukin-15. And the interaction there is tending to drive an inflammatory response, the development of those autoantibodies, and causing the inflammation which damages the lining of the gut. So some of the early results from this medication, it's FB102, if anyone wants to Google it later, is that they're seeing a reduction in the number of the inflammatory cells and an increase in the number of the protective immune cells. So that's a really good biomarker. That's one of the things which we can measure on a blood test and say, yep, it looks like a good efficacy marker for something which should help for celiac disease. Okay, nearly finished. Second thing is just an improvement in the lining of the intestinal tract. So this is something which is looked at on endoscopy and something called the VHCD ratio. And basically you're seeing an improvement there with a return of normal appearance of the lining of the gut. So again, it's another really good indicator that the medication might be helping. The third and possibly the most interesting thing, because it's not something which is really played out in a lot of clinical trials, is that we're actually seeing some improvement in the symptoms. So people that take a gluten challenge as part of the trial, they're actually seeing significant improvements along with these biomarkers for the group which are taking the trial medication. So it's certainly very positive findings. I'll admit that it's early findings and we can't be certain that it's going to all play out once a larger group of people are tested, but it certainly looks like it could be something which is a very promising mechanism and something which is worth pursuing and taking forward with the next round of testing. So if any of this sounds interesting, we would love to talk to you. Signing up to our database doesn't mean that you're committing to a trial, it just means that we can contact you if something interesting and relevant comes up. Then we will provide you with information and you can decide whether to proceed or not at that point. You'll be helping to shape the future of celiac disease care, and we'll do our very best to make sure that that's a positive experience for you. So thank you very much.
One question that we had is about the modern diet and processed foods, GMO foods, and whether there's links that are showing up in studies about the incidence rate of celiac disease and whether the modern diet is having an impact on that.
I don't know if it's possible to say there's a direct impact. Obviously, the modern diet is part of the environment that might play into predisposing risk for developing celiac disease. Clearly, there's a lot of anxiety and a lot of understandable interest and concern about the overall adverse or overall potential adverse effects of ultra-processed foods, and in particular the effect of those ultra-processed foods on gut inflammation. But I'm not aware of specific evidence directly linking, a highly processed diet and the development of celiac disease. I don't know, Claire, do you?
No, I don't know of any direct or causal link, but obviously, there's a lot of research going on looking more at a population level in terms of how the change in our food system to more of an ultra-processed food system and how that has implications in terms of some health and disease outcomes. But I've never seen any direct link with the increase or prevalence of celiac disease.
Great, thank you. The next question, kind of a summary of 3 or 4. So how does FODMAP affect the diet, the gluten-free diet? And what specific food causes bloating? And does fasting help with gut health?
Shall I start with that? Thank you. So FODMAP's interesting. I mean, I think I talked a little bit about when I was talking about increasing our dietary fibre, that for some celiacs, they are quite sensitive to some of those high fibre foods, some of those FODMAP foods. And so, because some celiacs do also have an overlay of irritable bowel syndrome. So that's why I say exercise caution when you start increasing high fibre foods into your diet and the types of high fibre foods. And if you do get a lot of discomfort and, particularly bloating, then it's important, obviously, to maybe work through that with a dietitian or a clinician. do you have much, John, do you, in your practice, do you see much of that, FODMAPs being used for people with celiac disease who might have a bit of IBS overlay?
Not a huge amount. Yes, as Claire says, there's clearly an overlap between celiac and IBS type symptoms, or people with celiac disease who also have IBS, and there is a pretty robust evidence base now around the use of FODMAPs for IBS symptoms. I would say it's a pretty hard diet to adhere to. And if you're going to go down that route, it's sensible to, one, have support and input from professionals, ideally dietitians, and two, to consider using it as a time-limited trial, seeing if you respond positively to it, and abandoning it if it's not making any difference, because it is hard to stick to.
That's a really important point. I mean, it should be only really for 6 weeks, and then food's introduced thereafter. So it shouldn't be that everybody should be avoiding every type of FODMAP food in their diet.
Thank you.
Sorry, what was the other question? I forgot.
Fasting.
Oh, fasting in terms of gut health. Fasting is a really interesting thing, because there are lots of different types of fasting. So there's, intermittent fasting. There's people who fast for cultural or religious reasons, where it may be for, a week or 10 days. And then there's the fasting, which is where people eat during the day, but they finish eating at, say, 7 o'clock at night or 6 o'clock at night, and then have a prolonged fasting overnight. So it's really hard. And there's most of the research in fasting is really around metabolic health. So, diabetes and weight issues. I haven't really seen any research, I don't know whether Suzanne and John has, around looking at whether it helps with gut healing. For me, it's really important to feed the gut. So even I know when people feel really uncomfortable, if they've been glutened, for example, or they are a newly diagnosed celiac that needs to obviously take a while for their gut to repair, you still need to feed the gut. It's the nutrients that make those villi grow back. It's the nutrients that help heal our gut. So, fasting might be good for some conditions, and it might make you feel better if you've got a sore gut, but it's also really important to feed your gut. I don't know whether you've...
No, I don't think I've got anything really to add.
Just a question on cross-contamination. So how important is it to avoid cross-contamination and as a celiac, and how can people ensure and gain comfort that they aren't being contaminated?
I can start with that. Suzanne might want to finish. I mean, yeah. I mean, it's really hard, isn't it? Because it's the level of cross-contamination, it's the level of exposure and the length of time of that exposure. I mean, a one-off, it is going to be okay, but if it is continuous cross-contamination and continuous exposure, that's when the damage really is done. And I think my kind of recollection of that with my daughter was the old toaster situation, not having a separate toaster for her bread, or chopping board, for example, and just thinking it was okay. But actually, over time, the level of contamination exposure that she was getting to gluten, even though it's really small amounts, just that, week on, week out level was enough to cause her some pretty devastating gut issues. I think it's also really difficult, isn't it? Because people have different tolerance levels, sensitivity. So for some people, a very minuscule amount of cross-contamination can make them feel really, really unwell. Whereas for other people, they can tolerate, much more contamination and not really know that they're being glutened. So I think that's quite difficult. I don't know whether you want to...
Yeah, I think it is a difficult one, isn't it? Because I think you want to provide the best possible care, but also from a pragmatic perspective, we live in communities, in families, in couples, in households, and you can't live entirely separately. So I often try and adopt a fairly kind of practical, pragmatic approach and say, yes, if you can, try and use separate toasters. Clearly, you're not going to be chopping gluten and gluten-containing and gluten-free foods on the same boards, but you can't have two separate kitchens, probably. You can't have two separate houses, probably. And I guess to some extent, it may make sense to be a little bit more kind of, well, certainly very vigilant at the outset until things have all settled down. And then when you know that things are under control, your symptoms are under control, ideally you're blood tests indicate that your celiac antibodies are negative and what have you, then if there's a little bit of kind of flexibility and a little bit of kind of, then at least you can watch for symptoms, you can repeat blood tests if necessary, because some people, as Claire said, are more tolerant than others, some people are more susceptible than others. So I don't think I've answered any questions there, but those are my thoughts. Suzanne, did you want to? Suzanne doesn't, but you like talking, Suzanne.
Seems to be a bit over this side.
Okay, the last question we've got time for. If you've asked a question and it hasn't been answered, we'll try and email answers to you. When you've got other family members with celiac disease and you've got the gene, what's the risk of getting celiac disease?
The risk of developing celiac disease if you've got a first-degree family member, i.e. a parent or a sibling or a child, is about 10%. So it's by no means kind of everyone, but it's significantly higher than the general population. Even in people who share exactly the same genetics with identical twins, there's not 100% concordance. So it is interesting that, the genes don't kind of dictate everything. They give you a risk, but they don't